Good morning or good afternoon to those of us in Europe. My name is Sanjog Kalra. I'm an interventional cardiologist at Toronto General Hospital University Health Network at the University of Toronto. It is my pleasure to bring you CHIP updates this month with Dr. Simon Walsh, consultant cardiologist at the Royal Victoria Hospital in Belfast, Northern Ireland. Dr. Walsh requires no introduction. He is a clear CHIP luminary known to all of us across the community and one of the most prolific CTO operators across the world. Dr. Walsh, thanks so much for joining us this morning.
Thank you very much for having me. It's a pleasure to join.
Great. Dr. Walsh, over the next few minutes, we're hoping to hear a little bit about the European CHIP experience and your feelings on some of the challenges and complexities of building CHIP programs and running revascularization programs in an environment that's a little bit different than the one we have here in the United States or in Canada. So maybe we'll begin by asking you what the largest differences are in the approach to complex PCI across Europe versus what we might consider complex PCI here in the US.
Okay, well, I think, to be honest, that things are broadly similar. I mean, we all believe in full revascularization where it's appropriate clinically, not for non-viable tissue and so on. But if there's ischemia and viability and these patients have disease that warrants treatment, we fully believe that it should be done and done as safely as possible. I think if you look at the differentiation between how we approach things in some countries in Europe versus North America, there are significant cost constraints in our healthcare systems that are very different. And using mechanical support is a lot less liberal than it would be in the USA, for example, purely as a function of the different systems rather than for good or for bad necessarily. So we are, very focused as much as everybody else is in trying to do the best job that we can for these complex patients, but also patients who've got difficult coronary anatomy. And it's very important that we approach this in a safe and a structured way globally as a community.
So you mentioned structured way. Are you using defined protocols to decide on what kind of revascularization you're going to do that go beyond the guidelines, or perhaps when you use mechanical support, or are these clinical decisions that are based on discussions between operators or discussions with referring physicians?
Yeah, no, I think that's very much the case. It's the latter. I mean, our heart team is a very key part of these decisions. Our surgical colleagues are valued and do a great job for a lot of these patients. And it's important that we do try and balance the benefit of an operation, open surgery versus a percutaneous approach. So that's one thing. And then as a group of clinicians, certainly we'll have broad discussions as well, just around how we should be treating patients most safely. What we'll tend to do actually is to double up as a team. And we get patients who are in a clinical state where they're at risk from a procedure. We'll have two experienced guys scrub together, work as a team and try and do the best job that we possibly can for the patient to keep them safe during the procedure. And that's not always feasible in a lot of healthcare systems, but I think it's something that really makes a positive difference actually to the procedure and to the outcomes as well.
So you bring up a very important point there around combination procedures and supporting one another during CHIP and complex PCI type of procedures. What do you think the top 3 or 4 benefits are of double scrubbing?
I think two heads are always better than one in terms of thought process, for sure. None of us have all the answers, even though we like to think sometimes that we do. I think if there's one thing that needs focused and another thing that needs prepared, we can split and it's very hard to concentrate on doing everything with 100% focus all of the time, particularly around hemodynamics, drugs that are being given, and even preparation of equipment, getting on to the next step, making sure that your procedure remains timely, sensible, and efficient. So, I mean, for sure, that's a big feature, I think, of these procedures, and having a second person who's experienced standing beside you, it just takes the pressure off. You get a lot less stress yourself, and I think the patients probably get a sense of that as well.
What about operator fatigue? Is that real?
Well, I think so. But, this is not, we're not generally talking about patients who are having prolonged CTO type procedures here. We're really looking at sort of, left main bifurcations, maybe a blocked right, calcium modification, those sorts of things. So I think operator fatigue can become a factor in very prolonged procedures, but a lot of this stuff is not into a 3, 4, or 5 hour procedure. So it's really just a case of keeping yourself efficient, safe, and sensible, and being able to just work through steps and not to lose focus on a particular point where you maybe jail a wire, you don't remove something, or it's very easy in these sort of procedures. There's maybe 50, 100, 150 steps through them, and missing one out or going in the wrong order is quite simple. But if you've two people there who very much understand what they're doing and are focused, I think that's a big help.
Mm-hmm. So sort of a check and balance almost with two brains better than one, two hands better than one, certainly. It's something that we find here, certainly in North America, and I think across the CHIP community, where we work more collaboratively than we do alone. Two approaches are better than one approach, etc. The economics are somewhat challenging sometimes, where, in managed healthcare environments or even fee-for-service healthcare environments, you have to somehow divvy up the operator time that you've put in. If you're employed by an institution, the institution needs you to justify how they can spend money to allow two operators. And these are obviously difficult problems that we can't solve in a 10-minute or a 15-minute interview. But do you have any thoughts on how to construct the data to justify these things? Is it a patient safety angle? Is it an outcomes angle? Is it a revenue generation angle?
Yeah, I think primarily, really, it's patient safety, isn't it? What we're looking at here, I mean, even though these procedures are difficult and the patients are at risk for sure, most of them get through pretty well. And the times that we get into a really deep struggle in the cath lab, thankfully, is quite rare. But I think what we're looking at is a good, complete, optimized revascularization in a very safe and managed way. And we need to make sure that the patient is getting the job done, in a complete fashion, and B, in a safe and managed way. How we sort of can persuade healthcare providers to fund that, I'm not entirely sure. We're lucky in the NHS, of course, that we're not in that type of environment. So we just purely approach this from a clinical perspective and put our sensible hats on and say, let's get this done as safely as possible and move on. And we don't have to, thankfully, have those thoughts or justifications around it.
Mm-hmm. Very interesting, where you especially for the most complex of cases, there's a conscious effort to divorce the economics from the clinical outcomes and patient safety, which I think is very important. And I think we all agree throughout the CHIP community that these patients require very careful, detail-oriented care that takes time, and there's no substitute to spending the time necessary to get the optimal outcomes that our patients need.
For sure.
Speaking of sort of approaches to revascularization, do you see any differences in the approaches to complete revascularization across Europe and in your experience than you've seen either in North America or in Asia? Perhaps protocolized approaches, the way you define your appropriate use, when you take on a CTO, when you don't take on a CTO, or is it all about what the patient requires?
It's just very careful consideration of all the information in front of you on an individual patient basis, and making sure that you've done the appropriate level of assessment, that you do understand things like viability, that you're not targeting very complex occlusions where there's dead myocardium. That's it's not helping the patient, and it's not helping the use of healthcare resource either. So it's an individual case-by-case basis. You have a very targeted revascularization that gives the biggest benefit to the patient, and you want to do the job in the safest way that you can. And I think there's a lot of our cardiology team who need to input into this. We've got our imaging colleagues, we've got our heart failure specialists, we've got a whole bunch of people who need to help us out with these decisions, and also in the aftercare of the patient as well. I think part of the paradigm here is that it's an expensive procedure to get through, but it's much more expensive in terms of healthcare utilization to not do it, because the patients will come back and back and back and back, and they'll be sicker and sicker and sicker every time. So the initial investment, I think, is well made, and people do tend to have a better outflow after it and actually use less healthcare resource once they get home.
Such an important point. So do you then function in Northern Ireland or in various parts of Europe as a hub and spoke sort of model for these types of complex procedures? Or, I mean, we find in North America that there are, for example, in the United States, I'm in Canada now, where we have a slightly different system, much more akin to the NHS, but in the US, you know, there might be 40 cath labs in a city, and the actual individual volume of complex procedures might be variable across labs. So should there be sort of institutional standards, operator standards in terms of numbers, training around being able to do these procedures? Should we be developing systems or referrals into centralized systems that are specialized in doing these types of things? Or are they, as long as you have two good operators, is good enough?
Well, I think both things are true, if that's possible. I think, you know, in smaller centres, if you've got two experienced guys or girls, I should say, working together in a sensible and safe way, and they're familiar with all the aspects of the procedure and each of the bits of kit and step and all, you know, everything that needs done, I don't think that there's a reason that they shouldn't undertake that sort of work. However, there are certainly cases that are of very extreme complexity right at the edges of the bell curve, and you know, those I think perhaps are best managed centrally with people who are doing this type of work all of the time. It's not the sort of thing that you want to launch into once or twice a year. But the reality of our patient group, I suppose, is we've got an aging demographic. We're seeing a lot more calcium. You know, these sorts of things, the surgical turndowns for comorbidity and so on, they're all around, and everybody is dealing with a certain number of them. Certainly in the United Kingdom, we have a different environment where the average number of procedures per operator is quite a bit higher than it would be in the United States, for example. So, you know, it's not to say should or should not, but certainly there's, you know, we all discuss cases with our colleagues. We like to support each other, and we're very happy to transfer a patient from A or B and work together and make sure we get the right outcome for the right person.
In large measure, it comes down to resource availability at a given center as well, right? If you have the tools, not every center will have every tool that you might need, and so you concentrate the cases based on resource availability.
For sure. Yeah, and you know, if you're using calcium modification and you're doing it once or twice a year, in a very straightforward case, okay, that's probably fine. You could probably do that safely, but if a patient's going to become very ill on you, that's not the once in the year that you want to be lifting the bit of equipment. So I think, you know, just sensible judgment is all that people need, you know, and doing the right things with a safety sort of hat on always is the way to approach it in my mind.
Great. And tell us, just as we wrap up, tell us a little bit about CHIP education in your experience and in the European, across the European landscape, and maybe a little bit about Optima, one of the excellent education initiatives with which you're involved.
Well, I think it's really crucially important, and I think what we need to recognise is that you know, any sort of complex system learning is a crucial part of doing it better, and structured education, I think, is very important to make sure that we can get patients safely through each of these procedures. We've just had Optima online there, and it's free for anybody to go and look at. All you need to do is register an email, and that runs through all of calcium modification, left main treatment, CTO, and everything else. And I think it's important that we put the education in a form that people can access it freely, but also that it's well structured and extremely well presented so that it's easily understood, and people can improve their practice as a result of it. We all have very busy jobs and a lot of work to be getting on with, and educational time's fairly precious, so it's really important to focus that down into maximum benefit for the time invested. So I mean, I'm obviously very biased, but I think the platform that we have it does that pretty well.
Wonderful. Well, that was fantastic. It never ceases to amaze me how, despite different environments, despite people working with completely different resources, as physicians in this space, we all seem to be devoted to the same thing, which is getting the very best outcomes for our patients safely and making sure that one another benefits from our shared experience and shared knowledge. And so that was just great. I really appreciate the time you've taken to speak with us today, Dr. Walsh. It was educational for me, certainly, and for everybody who I'm sure will be enjoying this interview shortly. With that, I will thank you all for joining us for CHIP Updates for this month. Stay tuned for more content.